Hello, everyone. This is Roxon Liu from Oakland, California, with a right femoral hernia repair on the new dV5 with 3D Max Mid. So this is a female patient with a symptomatic right femoral hernia. So I like to start my peritoneal flap laterally near the ASIS, and you can see the initial incision is somewhat of a vertical incision almost, and then I carry it across. And I try to stay in the preperitoneal space, or some people call it the visceral space. I try to stay out of the retrorectus space as I go medially here. Now, it's not, for me, a big deal to get into the retrorectus space, but I just find that there's a slightly better plane if I stay out of the retrorectus space. But in this case, you can see there's still some fascia left on the inferior epigastric side, the rectus muscle side, but not much. But you can see I found a nice avascular plane. Laterally here, I definitely want to stay against the peritoneum. So the visual cue is the fat and the vessels. I try to aim to keep the fat and the vessels up against the abdominal wall. I start as early as possible and just really try to hug the peritoneum, especially as I get laterally here. I don't want to get into the wrong plane and get into the space where the femoral branch and the the lateral femoral cutaneous nerves are. So usually once you start opening up the plane, things push off pretty easily. Look for those little vessels to divide with cautery so you don't get um, bleeding and oozing. So here I'm coming down onto the round ligament. Since this is a femoral hernia, I know I'm going to have to take it. If this were a direct or indirect inguinal hernia, I would consider saving the round ligament. But um, generally with femorals, my mesh is tucked just a little lower usually, so I just take the round ligament. I use some bipolar and then take it away from the internal ring so I don't have any chance of injuring the genital branch of the genital femoral nerve. So here I'm just peeling the microfascial layer off of the peritoneum. I'm not exactly right on the peritoneum. There's still another layer of microfascia on the peritoneum, but in general, there's usually a nice plane between the fatty tissue laterally um, and the you can say peritoneum. So immediately, I'm just sweeping. I'm going with what develops easily. There's a plane right up against the bladder, which I think of as a true spacer retius. And then there's a plane of anterior or ventral to the fat. In this case, I'm kind of in between the two layers, just trying to get down to where I expose the pubis and Cooper's ligament. So here's a femoral hernia. I'm not sure what this pause was for. Uh, this was fairly easy to reduce femoral hernia. You can see I just had to pull on it and it reduced. Again, notice the nice areolar plane that I demonstrate to myself. And that really just starts with good retraction. And the abdominal wall provides a counter traction. And here I'm just parietalizing the structures posteriorly, just making sure I dissect everything off of the microfascial layer that's over the psoas muscle. I don't actually want to expose the psoas. I want to keep that microfascial layer covering the psoas. Definitely want to see Cooper's ligament since I'm going to put a stitch to it. Uh, and going to cross the midline, get 2 centimeters across, get 2 centimeters deep to Cooper's ligament. You can see when the dissection is very hemostatic, you can go as far as you want without worrying about injuring critical structures. So I always go down to about the where the obturator space is right there, and I stop. Um, if for some reason I really want to tuck the mesh deeper, I will reduce the obturator fat. But most of the time, I find it unnecessary. Again, I'm trying to stay on the visceral side of the space. So there I'm showing the microfascia over, that's probably the femoral branch right there. That's the key, I think, to reducing chronic pain. I really don't want the mesh sitting directly on the exposed nerve. I want that microfascial layer over the nerve right there. So you can see the femoral defect, and I'm going to have lots of overlap all the way around. Uh, the mesh I always pre-place into the abdomen before I dock the robot, so it's readily available and ready for me to put into the pocket. There's less for my bedside assistant to do, allows me to be more efficient with this case. Here, just waiting for my Megas Tricot needle driver. And again, the goal is to cross the midline. I place the arrow just a little above the pubis usually. And the T is where the uh, round ligament meets the inferior epigastric. Just making sure my mesh tucks in well. And you can see there's going to be very nice overlap of the entire myopectoral orifice. And here, I always like to make sure that the mesh is laying flat, that there's room for it to wiggle a little bit, because when you desufflate, the space is going to collapse a little bit. And I'm going to place a single stitch to Cooper's ligament, which is my routine with 3D Max Mid. I usually put in 8-inch Vicryl just in case I need to show some peritoneal defects. For bilaterals, I also use an 8-inch. I just keep it consistent so my techs don't have to worry whether it's going to be a 6-inch or an 8-inch today. Just whether it's bilateral or unilateral, I just keep everything pretty as uniform as possible. Surgeon's knot, and 2 more throws. In this case, I want to slide it down for some reason. Uh, when it's when I really don't want the mesh to shift much, I secure the mesh down pretty firmly. When it doesn't really matter, I tie that knot a little bit more loosely. So there's the hernia contents. Now I'm just making sure that the uh, posterior edge isn't going to lift up. And you can see there when I lifted up the hernia contents, the posterior edge lifted up. So I definitely don't want to do that. That's it. Thank you for watching.